Tēnā koutou katoa. For those of you who don't know me, I'm Bev Lawton from the Women's Health Research Centre. Haere mai, welcome. Welcome to you all. It's with great pleasure I'll introduce you to our speaker, Professor Sarah Kilpatrick, who is over here working with us as an executive advisor on the program we're doing at present. And she has a huge amount of experience. Her CV's too long for now in maternal health, maternal morbidity and mortality. And she's also, way back when, some of you might know, we did a severe acute maternal morbidity audit. It all started with myself looking at the literature about what there was around to look at morbidity, maternal morbidity. And Sarah's name came up, as did Professor Stacey Geller, who's also here today. And then they got on a teleconference with us, or Skype or something, before Zoom, and it went from there, and they lent us all their tools. So it's with great pleasure I'd like to announce it. She's also, some of your CV, what do you reckon, Sarah? You've got it there, she's a professor. She's also a senior editor on the college AJOG journal. She's also done a huge number of publications and advises the CDC on maternal mortality. Thank you. Thank you very much. Thank you.
Thank you. Thank you. Thank you. Well, thank you very much, Bev, and it's really been an honor and a pleasure to be here. I've never been to New Zealand before, so it's been really fabulous, and I'm going to have a few more days after I'm working to really enjoy it. So thank you. So this is a topic that I've been working on for a number of years and started with Stacey Geller, and I'll review some of the work we did together, and then I will also update you what's happening in the United States with this topic. The no disclosures, objectives. So I want to start with why are we doing this at all? In this case, which is I didn't personally take care of, but I reviewed it when I was in Illinois, is a case that speaks, I think, to anyone in the room of something that is preventable and we should have been prevented. And that's really why we're looking at these severe maternal morbidity cases. So this was an 18-year-old, G2P0 woman who presented to an emergency room 5 days after termination with abdominal pain. She was not febrile, which confused the ER docs, but she was a bit tachycardic. They consulted everybody but GYN. She's 5 days after an abortion. They never called GYN. So she sat in that ED as they consulted GI, surgery, everybody but GYN. And 12 hours later, when they finally called GYN, who could make the diagnosis over the phone, which is, of course, retained products and endometritis, took her immediately to the OR, started antibiotics, and she died 2 days later from massive sepsis. So this was in Chicago, big city in the United States that has plenty of access to health care. And this is just an example of a truly sad, preventable case. And those of us who have reviewed a lot of maternal deaths, this was really we don't have enough deaths to study, so we have to study something else, and that's where we got to the severe maternal morbidity. Now, in the United States, we call it severe maternal morbidity, SMM. You were much smarter here to call it something that's easier to say, SAM, because everybody stumbles over the SMM, but they're the same thing. And, of course, the reason to do this is to prevent those cases that I just showed you, in addition to preventing or reducing the morbidity in all the other women, the much larger group of women who get really, really sick but don't die. And the whole point in any individual review is to look for patterns of improvement that you can then ultimately develop interventions that you can change in your local environment. And we don't have enough deaths to make meaningful decisions. This is data in California that showed in 2006 that maternal deaths were actually going up in the U.S., which is quite shocking given the amount of healthcare dollars we spend in the United States. And the U.S. basically, until about 2000, until these data came out, the U.S. didn't pay any attention to maternal death. It was just a topic in our Society of Maternal Fetal Medicine, which I was on the board. There was nothing on maternal death until around this time. Pushed by me. The blue line there is California's rates, and the green line is the U.S. In California, you can see at 2006, this maternal death rate went up to, this is out of 100,000 live births. But the point is that this was a shocking increase that nobody expected. In addition to that, as many of you know, that what's important on this slide is that the U.S. is the only country there that has the light gray bar that's going up, which is deaths going up in 2008 compared to 1980. And these are like countries in terms of socioeconomic status. So here's the U.S., who spends more money than all of these countries, having a worse maternal death rate than the countries listed there. So this also coincided with recognizing that the state and California are going up. What's important is that this is Cindy Berg's data out of the CDC. She published data to show, looking at the causes of death and the percentage of deaths by each of these causes. And what's interesting to me is that where that yellow line is, it shows that in the later time period, which is 2005-ish, compared to the 1980s, the proportion of deaths in the U.S. from hemorrhage dropped way down, which is good news. Probably reflects the work on toolkits, hemorrhage toolkits. But the proportion of deaths in cardiomyopathy and other cardiovascular conditions are going up. And of course, the proportions all have to equal 100, so if something goes down, something else is going up. But the bad news about this is that's probably a group of deaths that are much less preventable, the cardiomyopathies, cardiovascular, as opposed to the hemorrhage and hypertension. So the preventability data is important because no one likes to think that we as providers or we as hospital systems have a responsibility here or have a potentially we're not doing our best job. And in fact, that's really where the onus does fall. So these are old data from Chicago, Dr. Kemp, to North Carolina data. So the simple message here is the majority of deaths in at least 40% of deaths in the United States, and everything that's been published, have been deemed preventable. In other words, those women didn't have to die. And for those families, that's a very terrible thing to know. And I also want to point out that the first paper on this that talked about different buckets of preventability was in 1987. That's 30 years ago. And everybody ignored this paper in the United States. But this is the first paper that talked about you could be preventable, it could be provider issues, it could be patient issues, and both. He did not talk about system, which is actually the biggest bucket in some cases, and we will talk about that. Now, this I'm going to talk about Stacy's work and my work. Stacy really led this. This was her idea, and I sort of jumped on the bandwagon to help out. But this is now 2004. So more than 10 years ago, we published this, and nobody really cared about it then, right, Stacy? It's like we were pounding the walls to get it published, but now it's in favor. But so we asked the question: if you're going to study these women with near misses, we called it then, which is really the SAM group, are they similar enough so that we can generalize from them to the women who died? So the first question was, did they have the same amount of preventable factors? And in fact, this is what this paper shows, that in our group in Illinois, 40% of the deaths were deemed preventable, and 45% of the near misses were deemed to have significant preventable factors. In other words, if things had gone differently, perhaps they wouldn't have gotten that sick, which is the whole intention. This told us that, yes, there's an opportunity here for us to intervene and to improve outcome. And this is the concept that morbidity, most women don't go from being healthy and pregnant to dying immediately. There's a phase they go through. Now, the amniotic fluid embolus or the PE perhaps does, but those are really rare. But most women go through, they're fine, they're a little sick, they're very sick, they're nearly dying, and then they die. And so that's a long continuum that we could potentially intervene if we knew the right way to do that. The iceberg concept is that everyone's seen this image. At the tip of the iceberg are the women who die, but underneath that iceberg are all the women who get really sick. And that's the group we want to study, and that's the group we want to eventually implement change to improve. And there are a number, Bill Callahan's work from the CDC suggests that up to 0.5% of deliveries, 0.5% of deliveries. Now in the United States we do a lot of deliveries, 3 to 4 million a year. So up to 0.5% potentially are these women who have severe maternal morbidity or SAM. And his data are based on ICD-9 coding and now ICD-10 coding, which is not that accurate and over-represents this group. We'll talk about that a little bit more in a minute. In other words, it's 50 times more common than death. So it's clearly a bigger group. We're studying because the preventable factors are similar. So how do we define and identify these women easily, which is really an important crux of the issue? National surveillance is what the CDC does with their ICD-9 codes. And they have numbers, but they're very delayed. They're not real time. They're discharge diagnoses. They're dependent on if the coding is correct, et cetera. And the coding is often not correct. If any of you do work on ICD-9 coding, you know that. That's one way to do it. That's not very helpful for the individual site, though. So this is another view of his work from the CDC, and you can see this increase. So not only is maternal death increasing, but these SAM cases are also increasing, even at a bigger factor in the same time frame. So the 2011 is the bar to the right. And so we're going in the wrong direction there as well. This is just an example of their coding. The biggest problem in their codes is they include blood transfusion. So if a woman had just one blood transfusion, she will be coded as a positive. And most of us know one blood transfusion in pregnancy is often not a very big deal, so we wouldn't consider her very sick. And maybe she got a blood transfusion because she's a sickle cell patient and got a transfused for sickle cell, for example. So this is why their coding system for real research to find out what you should do, using ICD-9 codes is not very practical. So Stacy and I went on to try to tackle this question, and we got a group together at University of Illinois, and we said, okay, how can we identify these women easily in a current medical record system, whether it's electronic or paper, so that it doesn't take someone too much work to find them. And we started out actually with 11 factors, which we pared down. Our best model was 5 factors, but you can see, and it was very good, the sensitivity was 100%. We picked up all the patients, all the women who were severely ill, and some that weren't, of course, with the specificity being 93. But you can see, if you look at these factors, how do you easily identify organ system failure? I mean, who has a code for organ system failure and that's heart failure, respiratory failure, renal failure. So that works great in our model, but it's not easy to extract. Extended intubation, same way, and surgical intervention, which meant going back to the OR, unexpected back to the OR. So we thought, well, this is great, but it's not that simple. So let's make it simple, because we like simple. So the simple model was just 2 factors. So the ICU admission. So this is any pregnant or postpartum patient who gets admitted to an ICU in your setting. And it doesn't even matter how you define admission criteria. That doesn't really matter. Or who gets transfused 4 or more units of blood. And so this work was 2004, 13 years ago now. And again, when we first published it, people weren't that interested in it. But it's actually been repeated by one other study in the U.S. The Bill Grobman group did it 10 years later. They did a study to also say that it works. And the point here is it picks up a high percentage of the women who are really sick and doesn't pick up too many, so it's not too onerous. So finally, after this is the U paper, was essentially tested our model and came up with very similar. They did some slightly different things, but they came up with a similar conclusion. And so based on, finally, 10 years later, when people recognize that maternal morbidity and death are going up in the U.S., I became a part of a number of professional people in the United States to ask the question, okay, it's real, to remind people it's real. Now the question is, what should we do about it? And what we should do about it starts with how do we identify it. So we published what I call the Just Do It paper. Bill Callahan and myself and a number of others published this paper, which is pure expert opinion. We have no data to say why you should do it, but we published the paper saying, look, facility-based identification of women with severe maternal morbidity should be done in every single hospital that does obstetrics in the United States. And the factors that you should use, which this does have data, is just use ICU admission and or transfusion of 4 more units of blood, red blood cells. So that was the Just Do It paper. Which meant, frankly, it took us over a year to write this paper. There was a lot of differing opinion. People kept saying, well, you have no data to prove it's important. You have no data to show it works. And we kept saying, yes, we don't. But it's time to just do it. We have to find that data. And if we just sit around and people aren't reviewing these, we're never going to get there. How are we going to get the data if they don't review it? So those were national discussions with 20 people on the phone where sometimes you'd have to take the phone and go like this. And then we did the how-to paper, which is the same group of people, but it said, okay, the first paper was just do it, and now here's a how-to. And this was me and a number of people on a committee, and this also took over a year to write, and it was the same time point, overlapping time point. And this one was also filled with people being, lots of different opinions, lots of hours on the phone. But essentially, we wanted to give people a guideline. We didn't have data, it was the right guideline, but we wanted, and we didn't say you have to use this guideline, but here's a way to do it. And I think it's similar to what's been doing here. So identify these women with these 2 characteristics. Develop a multidisciplinary committee. That was key, because if you just review a case with just doctors, just maternal fetal medicine specialists like myself, we look at the case from our lens. We've heard a lot about lenses this last 2 days. if you don't add nurses or midwives to that group, or you don't add OB anesthesiologists to that group, or you don't add critical care doctors to that group if you need them, you're missing the entire story. And people tend to be overly critical when you're just looking at your lens. And the intent here was not to be overly critical, but to really evaluate what happened, decide what happened, first of all. That actually is not as easy as it sounds, because if someone dies, she dies. But if someone's just really sick and you're trying to decide, well, what are we trying to prevent? Are we trying to prevent the preeclampsia? Or are we trying to prevent the HELP syndrome? Or are we trying to prevent the eclampsia? Or are we trying to prevent the hemorrhage? So all that has to be decided. So a multidisciplinary group, primary data in that group, someone has to review the chart themselves first and then present a summary. If you bring the EMR or the chart to a committee with 10 people, you will spend 2 hours on one patient. So that's completely not useful. And then the real question is, are there any opportunities for improvement? Now, when I was in Illinois, Stacy and I used the terminology preventability. And it was either definitely preventable, not preventable, or maybe preventable. And everybody was comfortable. When I went to California, that was not PC enough. They didn't like that language. It was too blaming. So they said, we're going to use opportunities for improvement. Definite opportunities for improvement, no opportunities for improvement, or maybe opportunities for improvement. Yeah, it's like, okay, fine, whatever. We'll use a 3-tiered system. I don't care what we call it. It's the same thing. So we changed the wording. So this is the extension of this, and the bottom 2 points I want to make here. So the point to review is not to find the bad actor. It's not to find the bad nurse, the bad doctor, the bad pharmacist. It's to look at the entire system. And this was a big shift from peer review in the United States, which was all about finding the bad person. This is about system. And the idea is that you keep track of what you've learned in your system. And ultimately, and we're just beginning to do this, you try to set up some research to find out if you can actually improve outcomes by doing this process. So AJOG, finally, which is our national and Society of Maternal Fetal Medicine, and I was also involved in writing this, but this finally, so 2 years later, those 2 opinion papers were 2014, now finally 2 years later we wrote this, and this was another one that was fraught with people being, how can you say this, there are no data, and it was really about, look, this is the right thing to do. If we care about these women, all we're doing is saying you should review the cases in your setting if you do obstetrics. That's it. We're being very clear that that's all we're doing. So we did some work to look at the process in more detail. You get into the question of what actually, besides we use the definition, she's so sick she almost died, as near miss, and it's sort of, you know it when you see it. People wanted better. How else do you define the woman who has got severe maternal morbidity? What actually counts? She gets transfused 4 units, she gets transfused 3 units. So we did another paper in California with Elliot Main and I, and these are data from the California Maternal Quality Care Consortium, committee, which has done a lot of work in California, which has been great, and built a lot of guidelines for everyone, all free, by the way, for everyone to use. And we had 66,000 deliveries in California in this set. We then used the Callahan criteria, and if you use the Callahan criteria from the CDC, almost 1.3% of these women qualified for severe maternal morbidity. But when you actually reviewed the chart, we then pulled all these charts of these 66,000 positive women. It wasn't all 66,000, it's 1%, so there's 6,000 of them. We pulled the charts and reviewed the chart to ask, okay, do they really meet these criteria? And then ultimately you get down to it's about 0.7%. So people were afraid. One of the big pushbacks we got was this is going to be too many people to review and we don't have the time and ability to do it. The reality is, in any setting, it's probably only 0.5 to 1% of all the deliveries. So it's not going to be that many. So we showed that with this paper. We also showed that the rate for the ICU in 4 or more units is about 4.4%. And it's important to review the paper, your data. We then asked in the same paper, can we help get a better guideline or gold standard for defining what means a woman's really sick? Because as you start reviewing these cases, a large number of reviewers, I might say, oh, that's not that sick, and this person sitting next to me says, well, that's pretty sick. So can we help people define that, which is actually difficult. So we used our authors in the paper. We went through cases and we created these tables, which I'll just show you a couple. It's all in the paper. But to give you an idea, and this took a lot of time too, and there's a lot of going back and forth. So for example, OB hemorrhage who's had 4 more units of blood. Well, that's one of our criteria to pick her up. Everybody agreed. If she's getting transfused 4 units, that's pretty sick. So that's, but if she only gets 2 or 3 units and nothing else happens to her, maybe that's not that sick. And so we sort of said, okay, that's a no. Any emergency unplanned peripartum hysterectomy. So if they go right to hyst for a hemorrhage and she doesn't get transfused 4 units because they went to the hyst so quickly, she was a 45-year-old, et cetera, then that's still pretty severe morbidity, and she ends up without a uterus. You can't discount that. However, if it's a planned postpartum hysterectomy for cancer, which we still see occasionally, that doesn't count. So we went through this sort of back and forth process to come up with what we thought are reasonable tables. And we have tables for sepsis and pulmonary, et cetera. So just to give you an idea, this is useful if people want to use it. People don't have to use it. They can at least use it as a framework to help them decide. And people really wanted it to be defined very clearly because we want to measure it and you want to be able to be similar. But personally, I don't think it doesn't matter that much. If your committee thinks it's severe, it's severe. That's what I think. So the whole point of this is back to that is to prevent or find opportunities to alter outcome. And in the morbidity cases, as I alluded to, you have to define what you're trying to change. And most of us know we're not very good at preventing preeclampsia, despite baby aspirin, which might help a little bit. But in most cases, we're not going to, that's not the piece you're trying to prevent. You're trying to prevent the morbidity associated with preeclampsia. And thinking about preventable factors, so what's interesting, Stacy and I showed this in our work also, is the common factors, provider, system, patient. Patient was the least. Even though as a healthcare system and as a healthcare provider, you'd like to be able to blame the patient for, you really can't. The bottom line is they're the least common factor here in terms of preventability or improvement. And unfortunately, in most of the work that's been done, the provider falls out as the most common. And again, I've been teaching, I've basically lived in a tertiary care, quaternary care academic center for the last 35 years. So I'm part of this, part of you think, so you're responsible for this. So it's really not pleasant to learn that providers are still part of the factor. And again, it's not usually one person. It's the team of providers. And these are the common things. They failure to identify that the patient's high risk. Incomplete or inappropriate management, and the other thing I would say is wrong diagnosis. So, for example, the patient's got preeclampsia, everybody agrees, and the notes all say she's mild or preeclampsia without severe features, as we're supposed to say in the United States now. But when you review the chart, on day 3, she really became severe because all of a sudden she really had severe blood pressures, or all of a sudden she had elevated creatinine, so now she's severe. But nobody writes that in the chart, so nobody manages her that she's severe. They manage her like she's still mild. And so that is a delayed diagnosis, which then leads to delayed intervention, which then potentially leads to her eclampsia, or potentially leads to her HELP syndrome, or her DIC. So that type of thing is very, very common. Or you can't tell at all what the doctor's thinking, because there's nothing in the chart about what they're thinking about these new blood pressures of 180 over 110. System issues are everything between systems, communication between nurses and doctors, between the pharmacy, imaging, and doctors. Pharmacy, wrong medications not being available. Okay, so she had a seizure, but they couldn't find the magnesium because they had to go through the Pyxis, and they couldn't get it, et cetera, et cetera. Equipment, et cetera. So the process itself, I've talked about this already. To me, I think the most important thing is the multidisciplinary committee. I will talk about debriefing later if you want to, but it's different. It's not the same thing. So this is a website that's open to anybody. That's the safehealthcareforeverywoman.org. I hate that name, but it's free. It's open to, and it's really an AJOG-driven website. And this is the latest rendition, so this is what it would look like if you log on to it. And it has on here, you can see under patient safety tools, there's forms, and then to the right of that it says severe maternal morbidity reviews. So on this website has the form that I helped put together based on the California and the Illinois maternal mortality forms. And it also has on there this description of how to use it. So if someone's never done it before, it helps you, guides you through it. And one of the things that I like about this is as you're reviewing the cases, it's important to ask these types of questions. So if it's a hypertension case, the question should be, who's ever the primary reviewer, okay, was the hypertension recognized appropriately? Did she appropriately receive magnesium if she was supposed to? Was the severe hypertension treated? Did she get treated within an hour of her severe hypertension? Was she delivered? So those are the types of questions you ask as you review the chart and then ultimately decide, could we have improved, could we have done a better job? And the ultimate assessment would be done at the committee as they hear the case presented. And they have, at the time of the committee meeting, you should have access to the chart, either the EMR or paper, so that if a committee member has a question that the reviewer didn't look at, you can check at the time. So that really the discussion is a multidisciplinary discussion to try to answer those questions. We also think it's important, in addition to looking for could there be improvement, the negative part, we thought it was also important to have a positive part. Sometimes you have these horrendous cases where everybody did everything fabulously and you still had a bad outcome. It happens in medicine. So we thought it was really important for the team to recognize when this happened and actually keep track of it and potentially give feedback to your teams when you find something that was really remarkably managed, and even if the mom was really sick. The other point, of course, is the committee should be non-judgmental. This is not about finding the peer review issue. And in fact, if we find a peer review issue, it should be dealt with in a different committee. It should not be dealt with in a multidisciplinary committee. And that's really the rare finding. So the form looks like this. It was designed with the hope that someday it could be dumped into research. And most of these are drop-down boxes or fill in the box. And the first page is really a collection of some basic data about the woman. Depending on how much you want to use the form, this doesn't have to be used, but it's there. And we have yet to figure out a way to really dump it into a good data system. That's sort of on the to-do list. The case narrative is important. So the primary reviewer of the case really needs to say, this is a 22-year-old G3P1 admitted at 25 weeks with a headache, and just give a narrative of what happened. And this is why it's important to define ahead of time what morbidity you're looking at, because you don't need her entire prenatal course, potentially, or the entire hospitalization. You need the time period around when she had a morbidity. Now, you may decide when you look at that you need more, but the time sink of this process can be huge if it's not somewhat tailored. So the case narrative sort of gets typed in or written in. And then this is again, modeled after the maternal death forms, which is trying to put a sequence to what happened. So in this case, we have check off how you found her and other, if you just wanted to come up, use other screening characteristics. And then, for example, you might say, okay, she had, number one might be preeclampsia, number two might be severe blood pressure, and number three might be she bled in her head. So it gives you, this is what happened with this particular patient. Or three might be HELP syndrome and DIC. So that was helpful. And then this primary cause to sort of keep track of, so at some point someone might have some data to look at that. And then frankly, to me, this is the most important piece. And it's very simple. So does the committee think there was an opportunity to alter outcome? Could they have done a better job? And if there was, what bucket does it fall into? And all three could be. It could be all three of them. Maybe it's the patient because she didn't come to prenatal care until she was 30 weeks. And that's a complicated question as to why. And it's not intentional. It doesn't mean she's a bad woman. But that is contributed potentially to this woman who gets admitted with HELP syndrome. Or provider and system issues. List what could have been done better. And what we do at Cedars is we keep a record of these lists. Because at some point, when I've got three cases that have the same three things that could have been done better, it's time to sort of do something to fix it. We can't fix every single thing that we find, because we all know that if you try to fix 100 things in a year anywhere, nothing's going to get done. So you want to prioritize for your center what needs to be fixed. And then, as I said, we collect what went well and what recommendations can be made. So this is, there's a short form that I showed you. There's also a long form on that website which goes through all of this, really for if you don't know how to do, never done this before. So it's there. That's part of that. These are the questions. We made up these questions for whatever the major illness is to help the reviewer think. And then the long form also has this, which the short form, we don't use it because we've been using this for a while, but this helps you decide what are those system and provider factors. And if you want to keep track in your own system of what types of provider factors, so for example, if treatment is consistently suboptimal or there's a delayed response, or team communication, or policies and procedures, documentation. One of the things we found at Cedars is the poor documentation. It's shocking what people don't write when you cannot tell what they're thinking and they're doing things. And I guess it's one of my pet peeves. But so this helps you decide if you need this as a cheat sheet to help you focus on what the areas are. Same thing. This one is patient. The first one was provider and system list. This is patient factors, to be useful. And we have things like significant stressors, et cetera. So we have the ability to collect this and ultimately look at it in your own environment. So I'm going to go through two examples I made up, but for us, these are the types of cases we see and how the form might be used. So this is a 43-year-old with a known previa, presumed Akrita. We have a lot of those right now at Cedars. She presents at 37 weeks of hemorrhage. So they knew she had a previa. They knew she likely had an Akrita. She presents bleeding at 37 weeks. She goes to the OR emergently, and she has a cesarean hysterectomy. She gets hypotensive and tachycardic, develops DIC. The team has difficulty finding extra help in the middle of the night when this patient shows up. She bleeds 4 liters. She gets 8 units of blood, 6 of fresh frozen plasma. So they use the hemorrhage toolkit, which is nice, which says basically a 1-to-1 ratio between packed cells and fresh frozen. She goes to the ICU post-op intubated. She ultimately goes home on post-op day 4. So she ultimately has an okay outcome, but she ends up losing her uterus, getting transfused, getting DIC, spending 2 days in the ICU, none of which is particularly fun, and could have gone much worse. So the question there is, do people think there's any opportunity for improvement in this case? Who wants to offer a suggestion besides Stacy? If no one else will, we'll let her do it.
Someone else should.
What could have been better about this case? I don't know my audience. I don't know if you were OBGYN. Yes, thanks.
She might have been seen slightly earlier and a plan for her delivery date.
Perfect. Exactly. So at least in the U.S., when you have a previa and a known Akrita or highly suspected Akrita, we would say she needs to be delivered between 34 and 36 weeks. To let her stay to 37 weeks, we would say is completely wrong for this exact reason. She's going to go into labor at some point, and that's what happened. And the other part of what you said is really great, the plan. So we can say, okay, let's schedule her section at 34 weeks, but if we have no plan about who needs to be at that delivery, and these Akrita cases are terrible. So we right now have an Akrita team, actually, and so we have a GYN oncologist, we have our MFM docs, we have OB anesthesia, and we have a facilitator to help make sure all the appointments ahead of time get made, so the patient's met all these people, and there's a plan. So exactly. So this case definitely could have done. Now, what went well in this case, though, actually, and finding extra her surgical help. If you have no mechanism on your labor and delivery to find extra surgical help, that's a problem, because you never know when someone's going to walk in. Now, maybe you don't need it. Maybe your in-house people are capable of doing CHIS at a moment's notice. That's not the case in our setting, but we do know how to find people who can. So in that case, I'm not going to go through all this for the sake of time, but here's the idea of this box. Previa Akrita, placental hemorrhage, hysterectomy, DIC. Primary cause of morbidity in this case is a placental hemorrhage. So I'm going to get to this topic more at the end, which is our problem with prior cesarean sections. But these are types of primary cause morbidity we've been using to try to help categorize these cases to understand where the majority of them fit. Just a suggestion. And this, again, we put things that could be done. Multidisciplinary planning for Akrita before delivery, planned delivery before 38 weeks. I should say before 37. That's a misprint. And better way. And now, but look what went well. The lucky in-house team who got stuck with this case, the in-house people who were just taking their shift work, and this woman comes in massively bleeding, and you knew that her care provider knew she had a previa and a possible Akrita. Once you get over your anger at that care provider, they did a great job. They did the best they could have. She didn't die. She could have died, right? So that's important to say to your in-house team, you did a great job with this kind of case, and that's what we're here to do. Fix your buddies so that they don't leave you like this again. All right, so this is just a way to use it. So delayed inadequate preparation, should have been alerted, should have considered a Akrita team, which we found to be quite useful. I'm going to skip this. This is the same case, which interestingly, except they did everything right, and the point is, in this case, they did everything right, and she still bled. She didn't bleed quite as much, and she got transfused a little bit less, and the ultimate outcomes of both cases were okay. But when you think about moving forward, that first woman easily could have died. And so you have to think about this case as we got lucky. We didn't do the best we could do, and this time we got away with it. And frankly, in medicine, we get reinforced all the time for doing the wrong thing because it's really hard to kill a pregnant woman, right? We get reinforced all the time for not transfusing someone who has a hemoglobin of 6 because she's young and healthy and she does okay with that. It doesn't mean it's the right thing to do. So it's an important thing. So I'm going to skip that because I'm going to talk about some other. All right, so we did a study. So this is a study we did at Cedars I'm missing those previous. All right, so that, yeah. So we did this study. This is a fellow of mine at Cedars, and we wanted to look at what's the rate of opportunities of improvement in cases with SAM, and that hadn't really been looked at yet. We know it in death, but we don't know it in SAM. So we looked at women from 2012 to 2014. We screened them for SAM for multiple different ways to sort of pick up everybody, and I've alluded to most of these ways, but we included the ICU admission and transfusion of 4 or more units. We had the multidisciplinary team review it. We went through the exact way I just talked to you, so I'll skip that. And this is our sample. So it was 16,000 women in this time period, and most of them were screened negative by anything. 2% were screened positive, which is a really high rate. Remember I said it's 0.5% to 1%. But then we actually reviewed those cases. When we actually pulled all the charts and reviewed them, it comes down to our rate at Cedars-Sinai is about 0.9%. So that's a pretty consistent number, that 0.5 to 1. And I think it's probably true for most hospitals. And then we reviewed each case, as I mentioned. And this is what we found. So what's interesting here is our number one cause was hemorrhage still. Now, this is recent time period, 2012 to 2014, by a huge 70%. Number one cause of our severe SAM cases, with preeclampsia, eclampsia coming next, and cardiovascular being lower. Now, cardiovascular is now the number one cause of death in California, but it's not the number one cause of SAM, which is sort of interesting. We also found that if you look at the green arrows, that 44% of all of these cases still in 2012 and 14 is the same number that Stacy and I found 10, 13 years ago have opportunities for improvement, and which is really shocking. Most of them, second green arrow, are provider. 80% are provider. So it's like, oh my God, what are we doing? Nothing's getting any better. And what the good news here, you have to look for good news, right? So the good news in this paper is the group that had the least opportunity for improvement with hemorrhage. So it's 30%. Still not great, but it's less than the others. Now, the numbers are small. We have to acknowledge that. So maybe even though hemorrhage is common in our setting, maybe we're doing better managing them and doing a better job managing them. So we're now doing a study. That was 4 years ago, and now we're doing the same study. We've been doing our own Cedars multidisciplinary groups for that time period. So now we're doing a post-study to look at our opportunities for improvement, and I'm hoping we're going to find improved because we've implemented the system in our system to review all the cases. So what have we learned at Cedars? This is, I think, the interesting things, if we look at the choose 1 to 3 issues. So we learned in this process that our LAPS, we've been using calculated blood loss by weighing them standardly now for years, but for some reason, everybody forgot to do that in the operating room. So they were being weighed in the PACU, and they'll be weighed postpartum when she bled postpartum. But when they were actually doing the cesarean section, because of the amniotic fluid volume, everybody was still estimating it. And what we learned in our process is that they were being underestimated significantly. So the woman that then bled in the PACU or bled in the floor, people didn't realize she already bled 2 liters in the OR. They thought she just bled half a liter. But so she was way behind. So they were really delayed in recognizing the hypovolemia in response to blood loss. So we fixed that. This is what our CRETA team came out of these reviews, when we realized that we had a lot of CRETAs and they weren't being well managed or planned for. So that's an example of a direct intervention. So final thoughts about the review, and then I'm going to give you a little more other information. So I think this is really important. And I personally think that the process, I can't prove this, someday maybe I will be able to, the people who are on these review teams, and I have private doctors, faculty doctors, as I said, nurses, midwives, OB anesthesiologists, I have residents on, our fellows are on, and the people who are on the team when they review these cases get completely into it. They are like shocked by what they're seeing, and their eyes are open to how we are practicing in a way that they never realized before. And they're all individually good doctors, but they see how they see the gaps in how the system's not working together in a way they've never looked at before. So personally, I think they take that knowledge back with them to their daily practice. And I think that people on that team, and I'm not going to study this, it's going to be too hard, but I think their personal documentation gets better when they leave that group. So I think the actual process of doing this is going to have as much a beneficial effect as interventions that we might put into play. Now, I can't prove that. That's just my opinion. But we really do need data. So one reason to urge other people to do this is really do need data to show, hopefully, that this works, because it's hard to motivate people sometimes, particularly hospital systems level people, to allow people to have the time to do this if they don't think it's actually working. So I'm just going to review a couple other papers that have come out recently on SMM, which bring up sort of another issue. Now, this is a paper published in 2013, Miller et al. Group, and they asked the question, what happens when your first pregnancy was an elective cesarean section? Now, I don't know if you have that much in New Zealand, but in Los Angeles, it is not uncommon for people to come in, first baby, low risk, I just want a C-section, and they get it. Versus your first pregnancy was a trial of labor. So how risky, what is your subsequent risk after subsequent deliveries for severe maternal morbidity? And if we look at, can you see this? Yeah. So if you look at this, this is a composite, which is, here are the specific things: transfusion, hysterectomy, DVT, operative injury, death. If you look after the fourth pregnancy, if your first pregnancy was just an elective section, so she didn't have any VBACs, right? So there are 4 sections now. Her composite risk is almost 6% chance, that she's going to have one of these bad things by the fourth pregnancy. If her first pregnancy was a trial of labor, then after a fourth pregnancy, she's at about 1.5%. So these numbers don't sound that big, but these are bad things to get this. So the point is, definitely in the United States and many other countries where C-section rates are going up, we have a problem when that first delivery is by C-section that we need to address, which we're trying to. So we did some other work. This is also with Elliott Main, and this is going to point to the fact that the cases that have severe maternal morbidity also are related to the gestational age, which is going to bring in the need for care being at the right place. So we wanted to ask what risk factors for women at severe maternal morbidity, and to see if there was a relationship to preterm delivery, retrospective cohort study. We had 16 hospitals in California that we had from the preeclampsia collaborative we were part of, and we used the broad screening methods I've talked about. We basically did the process of review to decide whether the cases were true SMM or not, as I've discussed. And then what we did here is we compared women who had a true SMM or true SAM to women who did not have one. So the comparison here is a little different. So women who don't have severe morbidity, women who have a true SAM. And this is we started with 66,000 deliveries, 1.9% were positive, and then when we reviewed them, 0.7%. This is overlapping data from the other study, but it's a different study. And what was interesting here, so we're comparing negative women, so most of the women, 66,000 are negative, to the 491. Again, this gives you an idea of number of cases. Were true. And the age difference, okay, that's interesting, not that interesting, but if you look at the ethnicity issue, you can see that African American, non-Latinos, 14% of the true SMMs were African American versus only 8% of the SMM negative. So almost double in the true cases. And interestingly, Latina is not different. So people sort of lump Latina as the same as African American in the United States. It is not true. In the obstetric outcomes, the Latina women do the same as Caucasian women. So it's on almost every obstetric outcome, which is really kind of interesting. Here we have the gestational age of delivery. So 18% of the true SMM women delivered early compared to 1% less than 32 weeks. If you look at all preterm delivery, so term, and if you reverse that, so 92% of the women who did not have an SMM delivered at term versus only roughly half. So it's a huge related factor to preterm delivery. Now, it kind of makes sense. Preterm severe preeclampsia, sicker than, so it kind of makes sense, but people sort of forget about that. Multiple is a big issue. Prior cesarean delivery. Almost 60% of the women who had severe maternal morbidity in these 60,000 patients, so this isn't just one hospital, had a prior cesarean delivery. Again, illustrating that this is a huge factor. Now, of course, the sad news is that 30% of the others, the normals, had prior C-section too. But so odds ratio increased for less than 32 and 37 weeks, large odds ratios. What were the causes of this? So the majority of the underlying disease category is placental hemorrhage, 75%. Remember, most of these women had a prior section. So placental hemorrhage is a key bad thing that's happening. The rest of them are interesting, but the placental hemorrhage really stands out in a major way, and hypertensive disorders as well. And then the other way to look at this is that women who, when you break it down by disease category, of the women who had a placental hemorrhage, most of them had a prior C-section. So we're back to that. And most of the placental hemorrhages, of course, are the previous Accreta group. So conclusions from this paper is that hemorrhage, over half, and hypertension account for a majority of the cases, which is nothing really new, but they're just not going away. And what I think is really interesting, though, there's been a lot of focus now on heart disease being the #1 cause of death, but it's different in this group. It is a very uncommon cause of severe maternal morbidity, and it's probably because the women who really have bad heart disease die, or you manage them so well they don't get that sick. So we're not going to be able to prevent them as much. So we still need to focus in the United States on hemorrhage and hypertension. Whoops. And high preterm delivery rate, which I think people didn't quite realize too well, and placental hemorrhage is the key thing. So I think that this really brings up the factor, which I'm going to have my last couple minutes will be on. I hate to run over, so I'm going to try not to. Is this idea of maternal levels of care. And this came up this last couple of days a little bit. But in the United States, we have a pretty well mandated neonatal level of care system. So every hospital has a neonatal level, and that's pretty well done. Maternal levels of care is very erratic. And for many years, people sort of assumed, well, if you're a NICU level 3, which is the highest NICU, you must be a level 3 or 4 maternal site because it's highest. And the reality is there's no connection in terms of the care services available that's logical between that thinking. So interestingly, in the 70s, there was a number of documents written that we need to do regionalization of perinatal care, and that means babies and mothers need to have a level, and they need to communicate with each other. So in any community, if you need the appropriate level, you can get there. Well, the NICU side, the baby side took it on. The maternal side just didn't take it on. There are some states that do a good job. Illinois does a good job. Northern California does a good job. Southern California does a lousy job. Arizona does a good job. But it's completely haphazard. And it's not good for women. Because at 3 in the morning when someone comes in and is really sick, you don't know who to call. And you don't even know what your capability is, and so to define that. So these data suggest it's really important. We have really sick moms who might also have a preterm baby. They need to be in a setting that's good for both of them, not just a setting that's good for the 32-weeker. That's great. That needs the right doctor, but they also need the right critical care docs. So we need to do that. So there's now a big national effort that I'm also part of, which is also controversial, and we get into a lot of argument. I don't know why I get in these things, but I'm going to skip that one. So this document came out 2000. I'm sorry, so small. We just had to renew it. So 2 years ago, this came out, and this basically is a consensus statement, pure expert opinion, that says we need levels of maternal care in the United States. And what we mean by that is that we want facilities to be designated as an appropriate level for services for the mom, and number one, and number two, we want them to build relationships with lesser levels. It is not about doing away with the level 1 or level 2 hospitals, because most births in the United States are in level 1, level 2 by huge, like 80% of births are in level 1 and level 2 across the country. This is about aligning people together to take the best care of your patients, mothers and babies in your community. It is not about closing down level 1s or 2s. It turns into a political discussion because of finances in the United States. Hospitals don't want to lose their NICU baby because the mom is too sick, because the NICU always makes money. mothers never make money, but they would rather keep the really sick mom because they have a NICU that can take care of a 32-weeker. And then if they have to, they'll send the mom later. Well, that's terrible, right? That is just terrible for the patient. And then there's also this psychological competition in big cities of centers that think they should be level 4, but they don't really have all the pieces. So that's where we've gotten into a lot of discussion, and not everybody agreeing. But we pushed this through, and what we did, I'm not going to go through it in detail, but the premises are focus on best maternal outcomes and really right care at the right site. Put her at the site that she needs. If she's a level 1 mom, it doesn't need to be a level 4. You don't want her at a level 4 because we will do too much to her. Bottom line, right? We're used to sticking things into people all the time. And so keep her at the level 1. That's appropriate. Build relationships, align. So we have done a lot of discussion with all these groups. And from American Association of Birth Centers to midwives to nurse practitioners to family medicine, to get everybody on the same page, to the American Hospital Association, AHA. Complementary but distinct from neonatal, and it should be antepartum, interpartum, and postpartum. These are the levels we actually put out, and I'm not going to give you the definition, and I can send you the document if you want. But for the first time ever, AJOG, which is American College of OB/GYN, recognized birth center. Before this document came out, they had never sanctioned a birth center. So now it is sanctioned in this document. The definition is based on the American Association of Birth Centers. We didn't change that, but basically we said, for some women, if you're the lowest risk, this is a perfectly appropriate place to be delivered, as long as that birth center has communication or relationship with higher levels of care, has a transfer agreement, etc. And then we came up with these 4 other levels. And most of the argument is between level 3 and level 4. And there's not a huge distinction in level 4, but the big distinction is twofold. One is that the maternal fetal medicine people, like myself and Peter, have to have clear evidence of direct and co-management responsibility with any obstetric patient in an ICU. So you have to show that you have experience in managing patients in the ICU. You don't have to be the manager. You can have your critical care docs, but you have to be able to show that you don't just give her up to the ICU and never see her again. You actually co-manage her. And you have the subspecialty services to manage things like neurosurgery in pregnancy, renal transplant in pregnancy, heart surgery in pregnancy. You have to have the super subspecialty things that are pretty rare across the country. So that's sort of the level 4 distinction. And this is going to be my last slide, and this is the good slide in that it's the same slide you saw at the beginning, except the difference is it goes out to 2010. In California, you can see the 16.9 was 2006-07, where the maternal death doubled from 1999, has dropped their maternal death almost back to baseline in this last 4 years, and which is really terrific, and mostly probably due to CMQCC's hemorrhage and preeclampsia toolkits. The United States as a whole, the green number, that's 16, not 6, is still going up. So we still have a big problem, and I do think that advocating for review of these women with SAM is really important and ultimately will lead to better care. And I thank you very much. I'm happy to take questions. Yeah, so that's a good point. So the question is, what about external review versus internal review? I think that's a really excellent point, and it came up as a discussion point when we wrote this document. And the thinking was that we would like to leave it to the local level. And in some cases, like in Illinois at the perinatal centers, actually, before I left there 6 years ago, we were reviewing at UIC the SAM cases from the hospitals in our network. And I think that's a really great model. But because we were starting from the beginning to mandate that, people are so afraid that you're going to find something bad. So we did not mandate that. It's talked about in the document that this should be considered, particularly in settings where the volume is really low. So in little tiny hospitals that might have 1 or 2 cases a year, we did talk about their partner, theoretically their higher level partner should potentially be willing to review those cases at least with them. But I do think it's appropriate, and if you find yourself in a situation where there's never any improvement for improvement, you know that those aren't honest reviews, because nobody has a never scenario. But I think that's a really good point. Any other points or questions? Yeah?
Yeah, thanks. It's really interesting and great.
Thank you.
And also, so you kind of set it up with local review in mind, really, isn't it?
Yeah.
Process to set up. For your smaller hospitals that you include in maybe to review their cases, do you include their staff in those reviews? Because it strikes me that that's where a lot of them really different.
Yeah, so I don't, the answer to that would be ideally yes. This is sort of still a work in progress, and not everybody in the country is doing it yet, and we're trying to ratchet up the expectation for that. But I absolutely would agree. I really think that including the people who care for the patient, not that individual patient, I mean, you don't review your own case, but including the people who care for the patients in their own setting and the process is really important. So I really think on-site review, maybe with an external person to help guide it, if there's a concern that they're not being appropriately reviewed, is useful. Because if you take it all off-site, then the people who need to learn are missing the whole process. So I think that's a really good point.
It's not learning from someone else.
So aren't learning from something else. Another point I want to make, which I forgot, I think I skipped over it. We made it very clear, the Joint Commission, JACO, on hospitals in the United States, is the organization that comes into hospitals and basically grants them the ability to continue working or not, and everybody gets reviewed every X number of years, and every hospital is scared to death when it happens, and because no one wants to be shut down. And they can be quite onerous. And one of the things they mandate are something called sentinel events, which when you have something really unexpectedly bad that happens, it has to be a sentinel event, and there's a whole sentinel event process that the entire hospital gets involved in. It has to be reported to JACO. So when we started this process of defining what this was 4 or 5 years ago, we had people in our group that wanted all of these reviews to be sentinel events. And I was adamantly opposed to it. I said, that is the wrong way to go. If we set this up as a punitive example, people won't do it. And we went so far to have multiple discussions with JACO on the phone and in person, and I had colleagues who were arguing with me. Luckily, it wasn't just me who thought it was wrong. But we finally got it pushed through that they are not considered sentinel events, that JACO was fine with that. All they wanted is for them to be reviewed. And then you could decide on an individual basis. You might have a case that's so egregious, you want it to be a sentinel event because you want to alert the entire hospital that it was a problem, or maybe the system change you need is beyond your unit. So they are not meant to be sentinel events unless the individual group wants to do that. In the same way, they're not meant to be quality metrics. We are very against that too, because if you make 4 units of blood or admission to the ICU a quality metric, so if it becomes a ding if you do it, so we start reporting out rates of that, someone's going to say, well, maybe she doesn't really have to go to the ICU. Maybe she only needs 3 units of blood. So we didn't want that level to translate into doing the wrong thing, because that's often actually what the woman needed is that. So we're really, and that's written all over our documents as well, to avoid the punitive side of this. But rather this is about how can we take care of these patients in the best possible way to have the best outcomes. Thank you very much.
Thank you, Cedar. I just like to thank you. It's good to see she seems to win a lot.